Good morning, everyone. This is Mark Urken, and welcome to the October 14th Thyro MPS session. We are thrilled this morning to have a truly international tumor board session, and want to thank our colleagues in Japan, Dr. Sugitani and Dr. Kazusaka, for their efforts in putting these cases together. As always, I'm going to turn over the session to Dr. Tuttle, who will make the introductions and get us started here.
Fantastic. Thanks, Dr. Urken, and welcome to everybody to the panel. This is going to be some wonderful cases, I think. Let's do our usual thing, and we'll just go around the screen here and have folks introduce themselves. Let's do the right-hand column first. Dr. Pitoia.
Good morning, everybody. My name is Fabian Pitoia. I am an endocrinologist from Argentina, head of the thyroid section from the Hospital de Clínica University of Buenos Aires.
Beautiful. Thank you. Dr. Cabanillas.
Hi, I'm Maria Cabanillas. I'm an oncologic endocrinologist at MD Anderson in Houston, Texas. My area of expertise is thyroid cancer, and focus with advanced aggressive forms of the disease. I lead our ATC program here.
Thanks, Maria. Dr. Khorsandi.
My name is Azita Khorsandi. I'm a neuroradiologist at Mount Sinai Health System.
Perfect. Dr. Baloch.
My name is Zubair Baloch. I'm a professor of pathology at the University of Pennsylvania Medical Center in Philadelphia, and my specialties include cytopathology and endocrine pathology.
Perfect. Dr. Coura-Filho.
Hi, I'm George Coura-Filho. I'm a nuclear medicine physician in the University of São Paulo, and my research field is in endocrinological neoplasms.
Beautiful. And Dr. Sugitani, I'll turn it over to introduce you and Dr. Kazusaka, and then we can start the cases. Professor Sugitani.
Oh, thank you very much. Hi, everyone. I'm Iwao Sugitani. I'm a thyroid cancer specialist working at the Nippon Medical School, Tokyo, Japan. I'm really glad to be here today. Thank you.
Perfect. And Dr. Kazusaka?
Thank you very much. Good morning, everyone. I'm Hiroko Kazusaka, an endocrine surgeon from Department of Endocrine Surgery, Nippon Medical School, Japan.
Fantastic. Well, thank you both for joining us, and I look forward to the presentation. So let's go ahead and start the first case.
Thank you very much again the invitation, and let me get started. Case 1. Case 1, a 59-year-old woman noticed hoarseness in November 2019 and visited a local ENT doctor. There she was shown to have left vocal cord paralysis, fan masses in bilateral lobes of the thyroid, and multiple lymph node swelling in the bilateral neck. She did not have any particular past illness or family history of thyroid disease. 1 month later, she was referred to the Oncology Referral Center for neck surgery. They conducted 5-needle aspiration cytology on thyroid tumors and lymph node. The results showed a suspicion of medullary thyroid carcinoma. As for tumor markers, the serum CEA level was 295.9 and calcitonin level was 7,260, both of which were very high. In addition, abdominal CT scan reveals that she had multiple liver metastases and bilateral adrenal nodules. Both urinary metanephrine and non-metanephrine levels were also high. There was no parathyroid disease.
So let me have you pause there for just a second. Go back one. Dr. Pitoia, what are you thinking thus far? We've got this information sort of top line. What are you thinking here?
Well, I would say that for us, it's not as frequent to have a fine needle aspiration showing a medullary or suspicious medullary thyroid carcinoma. So we probably will have a category 6, but not typified or subtypified what kind of tumor we are seeing. So, and sometimes we do not ask for calcitonin as a first measurement, and sometimes we need to repeat the fine needle biopsy So what we see in our real life scenario, not I mean in my hospital, but we can see that perhaps we have a delay in the diagnosis of these kind of tumors for some time until somebody asks for the calcitonin, as it is not a routine measurement here in Argentina.
And Zubair, I think Fabian's right. We often don't think about medullary cancer on the FNA, but you'll get, what are the descriptors that come up on that should at least make us think about medullary, Zubair?
So, you know, so the classic teaching is that if you have something which does not look like your regular run-of-the-mill FNA, like papillary carcinoma or follicular neoplasm, you should always think of medullary. In the old teachings, the medullary was always called melanoma of the thyroid. That means it mimics other tumors like melanoma does. So even that suspicion raised in FNA is enough to really think of medullary. And the most confirmatory test that is available is doing serum calcitonin, or you can even use the FNA rinse to do calcitonin level to confirm that suspicion that was raised on FNA. So to me, even that suspicious of a medullary carcinoma is almost equal that it is compatible. Now, it is a rare tumor, so some cytopathologists see it in reference centers more than the others. But I think it's a very much indicative, even when somebody calls it suspicious for medullary thyroid carcinoma.
Maria, these calcitonin numbers of 7,000, CEA at 295, is this in the neck? Is it helping you sort of get a picture already before the imaging? What are you thinking here?
Yeah, I mean, when you have a calcitonin and CA that are that high, you should always suspect that the patient has distant metastatic disease. And so you should do cross-sectional imaging, basically of the axial spine and the body, because medullary likes to go to the liver, it likes to go to the bones. We see lung metastases. And so, and the other thing is that with this particular patient, you want to look at the adrenal glands, of course. I'm sure you're going to touch upon that in a moment. But this calcitonin is very suspicious for distant metastatic disease. The guidelines, I think, go a little bit too low in terms of what they recommend, the ATA guidelines, which I believe is 250. We see calcitonins in the thousands, even with just localized disease. So, but you should still always check before you go to surgery.
Okay, let's keep going through the case. Hiroko?
Yes, subsequently, red germline genetic testing was conducted and exon 11 codon 634 point mutation was confirmed. Afterwards, her mother and 2 children were revealed to have the same red mutation, but no one has developed medullary thyroid cancer or related diseases as of now. She was referred to a university hospital to have adrenal surgery first. In June 2020, she underwent right laparoscopic adrenalectomy for pheochromocytoma. Then she was referred to our department to consult regarding the treatment plan for medullary thyroid carcinoma.
Okay, let's pause just a second. I can't go past this, Maria, without at least saying a couple of words. We always say do the germline testing, and then so what do you, this 634, what's it mean? How does it help you?
Yeah, so this patient is very suspicious for hereditary disease. And so you need to rule out, you need to at least rule out pheochromocytoma before you take a patient to surgery, because the surgery could be disastrous for the patient if they have a pheo. This patient had bilateral disease in the thyroid and has adrenal nodules. The biochemical testing is suspicious for pheochromocytoma. So the patient was tested for germline RET, which every single patient, whether they have a history, a family history of medullary thyroid carcinoma or not, at diagnosis, they need to be tested for hereditary disease. Because, for example, this patient was the first one identified in the family. So if you can't wait for the genetic testing, which oftentimes can take weeks partially because of insurance clearance, then you can always just check for pheochromocytoma and hyperparathyroidism before they go to surgery. Hyperparathyroidism, because you want to be able to remove parathyroids at surgery if you're in the neck already, and pheochromocytoma because you need to address the pheos prior to going for thyroid surgery.
Fantastic. There's lots we could talk about this case, but what I want to focus on is sort of the initial surgery, because Dr. Kazusaka's question for us is this initial surgery. So let's go ahead and look at the imaging and take us through that, Hiroko.
Next, please. So these are the CT scan findings from her first visit with us. You can see left upper neck lymph node and left middle neck lymph node. The bilateral thyroid tumors are remarkable, and the tumor in the left lobe seems to invade the recurrent laryngeal nerve. And multiple liver metastases like this were also evident. And you can see left adrenal swelling here.
Okay, take me backwards one slide. Dr. Khorsandi, incredibly unfair to ask you to say anything about two images on a PowerPoint, but that's not going to stop me whatsoever. Initial thoughts when you're looking at this, or help us understand when you're looking at this, what are you looking for, knowing that Mark's going to be thinking about a surgery? What are the things you're thinking about here?
So I can't make a diagnosis based on CT. I make that very clear. You know, we see thyroid cancers and you have to go to FNA. The things that I would give to the surgeon is there tracheal invasion? I think they already know if there is vocal cord paralysis or not. You see the lesion at the tracheoesophageal groove, which they already talked about. You also talk about if there is substernal extension, most important extrathyroidal extension. So the surgeon is aware of. I do talk about central compartment nodes, and I do talk about specifically lateral compartment node, up to what levels. And then I stop and lower my head and go away.
That's perfect. Dr. Coura-Filho, there's like nuclear medicine studies that you guys use for the medullary cancers. You know, where do we kind of stand with that right now? Because, you know, we're thinking this is probably distant mets. Role of nuclear medicine helping us imaging medullary here, George?
Yeah, since the advent of PET-CT, we've been studying several radiotracers to do a one-stop shop. It's a dream, like to stage the whole body in a single examination. But at the present time, we haven't found something that is as good as separate individual examinations like neck ultrasound, dedicated chest tomography, or magnetic resonance of the liver. A couple of years ago in our group, we've published a paper in JCM studying somatostatin analogs receptors. And when we look separate every compartment of the body, the PET-CT had an improved diagnosis only for bone disease. But if you think that you can use a contrast-enhanced CT and separated lung chest CT with the PET-CT, you can have a good examination. In this case that has a germline mutation, also PET-CT is very good for pheochromocytomas and paragangliomas with somatostatin analogs. So we can use these. The trick is to choose which analog you are going to use, since you have a variety of affinities for each kind of receptors. If you are using DOTA-TATE, DOTA-TOC, DOTA-NOC, DOTA-LAS, DOTA-BAS, DOTA-LAN. So in nuclear medicine, the trick is to choose the better radio tracer to do the imaging. And nowadays we are having some studies using some other biomarkers like fluorocholine to track cell proliferation. And we also have FDOPA, which is an amino acid analog that seems to have an improved value to evaluate medullary thyroid carcinoma. But one thing we have always to keep in mind is that they all have a complementary role to FDG, because when things go sour, FDG seems to be the best radio tracer to evaluate very aggressive disease.
Yeah, Mark and then Maria, let's go to the heart of this. The heart of this is, Mark, are you just going to do a surgery and clean things out? Or we know this as a RET mutation because it's germline. Or are you going to involve Maria to say, can we shrink things before? So where are we in this sort of surgery versus neoadjuvant space? Mark first and then Maria. Mark?
Yeah, I would be thinking about doing some DOTA surgery. But if you go back to the previous slide of the neck, I would agree with what, one more slide back, with what Azita was commenting on. Right there. I think the fundamental question is really, first of all, can this surgery be done safely, and should it be done at the outset here? And so obviously, our antenna goes up that the left vocal cord is out. And I think it's most likely, based on this imaging, to be due to the recurrent laryngeal nerve, even though that level 4 disease appears to be involving the carotid sheath with compression of the jugular vein anteriorly. It appears to be fairly well circumscribed. So I think the essence of this is that the left thyroid disease has knocked out the left recurrent laryngeal nerve, and therefore the pressure on the surgeon is to make sure that right nerve is preserved. I think because of that, and certainly I would certainly want multidisciplinary input here, and I would look to Maria to agree with the plan, but I think saving that right nerve and going in at this time makes the most sense.
Maria, where are we on this? I mean, these neoadjuvant things, it just makes such sense to do it, but sometimes what makes sense isn't always the right thing to do. Where from a research setting and from a real, patient care setting, where are you on that sort of neoadjuvant in this RET specific area here, Maria?
Yeah, with RET specific, it's experimental. So we have clinical trials for neoadjuvant therapy for different diseases. We have one specifically for RET mutation and RET fusions. And I think, it's helpful in other, more helpful, like in anaplastic thyroid cancer, where you can really change the surgery that the patient's going to have. I'm not sure that this patient would gain much from neoadjuvant, and so, I would consider putting them on the trial if the surgeon was on board with that, but I probably wouldn't offer it outside of a trial. I'm not sure it's going to save that left vocal cord, and that's really the reason why we would do it. For example, if it were encasing the carotid, then that's a good reason to try that. But again, it's still experimental.
Dr. Pitoia, every month or two, I get an email from somewhere around the world that says the patient has distant metastasis. Should I even really still be doing a surgery? Should we just be going to systemic therapy? I mean, we're assuming this is distant met. So talk a little bit about, are you still going to do a neck surgery in somebody that has presumed liver mets? How you think about that, Fabian?
Sorry. I would like if you could speak a bit slower to understand the question.
Fair enough. So in the setting of the distant metastases,
yeah,
are we really going to do a thyroid surgery? That's the email I get from a lot of people. So what do you think?
Sure. There's no doubt that you continue with the local treatment than to be able to do systemic treatment with the progression is observed in this group of patients. But we have to understand also that the different facts from around the world make this discussion very different, because we in Argentina, we do not have sulpercatinib and pralsetinib, and we had it for a couple of months as expanded use program, but now these companies saw that the number of patients were really very, very high. They stopped the compassionate use program. So now we do not have any of these alternatives, and we have to think only in Banderanib, because we also do not have cabozantinib as approved in Argentina and in many regions of our countries in Latin America to be used in medullary thyroid cancer. So this is a complete different fact from US, for example.
Absolutely. Well
Yeah,
said.
Mike, I'd like to just also, because I'd like to just mention that these drugs, these targeted therapies, they all eventually stop working, right? So even if you treated the patient up front, if you had selpercatinib or pralsetinib, access to these drugs, eventually you're going to be back where we find ourselves now, which is we need to operate because the airway is at risk.
Right. And the goal here is local control. Okay, so go ahead, Dr. Kazusaka.
Yes, so we thought that the patient had two options for treatment plan. However, specific inhibitors were only available by clinical trial at that time in Japan. And based on our surgical experience, so primary MTC is not so invasive compared to papillary thyroid carcinoma. So we presumed that we could perform R0 resection on her neck. And we also expected that reduction of tumor burden may enhance the effect of drug therapy. In July 2020, we conducted total thyroidectomy with bilateral neck resection for advanced MTC. We accomplished R0 resection and were able to preserve the right recurrent laryngeal nerve with complete function. And here are the pathological findings. It was a medullary thyroid carcinoma with 14 pathological lymph nodal metastases. Necrosis was not seen. Stromal deposits of amyloid can be identified. They were positive for conglomerate. The tumor cells were immunoreactive for calcitonin, and the Ki-67 labeling index was 5 to 10%. And
Okay.
I
was going to say, let's pause there. Zubair, there's been sort of a change in how you guys are describing these medullaries. We weren't used to high-grade medullaries before. Can you talk a little bit about so we understand what those reports are going to look like now?
Yeah, so, I mean, it's not like we're talking about it now, we are bringing it to the front because we always realize that the tumor which follow neuroendocrine patterns, that means they have nested growth like in carcinoids or other neuroendocrine neoplasms throughout the bodies and even pheochromocytomas, that when you saw mitoses, and even in thyroid cancers, which are non-medullary, it was something to be really careful about because that means that the tumor proliferation rate or it's kind of has features which are going towards being an aggressive tumor. And I think then the era came and we got all tuned to looking at tumor necrosis. And most of these tumors do not have necrosis, but when you submit a good amount of tumor, you realize there are areas when the tumor goes under what is called the chemidonecrosis. That means it's a true tumor necrosis, not because of FNA or because it's just an area of edema or hemorrhage. And I think two major studies that came from, one of them is from your institution, from Memorial, Rani Hussain and Ben Zhu were part of it, where they described certain features to look for in medullary carcinoma, which were associated with higher recurrence rate or poor prognosis. And most studies which follow up also showed that up to 25% of the medullaries can be classified as such. So again, those similar findings that you see in other neuroendocrine tumors, mitosis and the mitotic count of greater than 5 and 2 millimeter squares, Ki-67 proliferation index, because the mitosis is in the eyes of beholder. My mitosis may not be somebody else's mitosis. And then necrosis. Then I think all of those authors got together on an international scheme and they found that if you have even any one of those features present in a medullary thyroid carcinoma, as was pointed out by the I'm sorry, Dr. Kazusaka, that, most of these medullaries are going to be non-invasive tumors like we see in PTC or follicular. So I think these things are very, very helpful. Now, there has been some validation studies to look, even if the pathologist agree on those features when they're reviewing this, what is the variability? And they found that when you have these three features, most pathologists are able to identify it and come to an agreement. Now, there's a recent study from Italy which showed that the necrosis far more succeeded being a top level variable to really identify these high-grade carcinomas. So it's a process, but WHO has recommended this because I think this is one of the major findings that we can focus on. And I sign out my cases now saying low grade and high grade. But I just want to add 1 second, Michael, just want to add that, there are other features in medullary that one also should be careful about. Like I have a case that it is low grade, and Dr. Lavolsi also shared that case with me. And also we discussed it in the tumor board. It is a low grade tumor, but it has multiple foci of angioinvasion. Now, where do you put that tumor in? So, we still have to be cognizant of those traditional factors that we look for because they have proven over time in thyroid tumors. But I think this is a great tool to recognize these, especially for folks who don't see many of these tumors. I hope I answered the question. Mike, you are.
That's awesome. That's helpful. Dr. Sugitani, what I would like to do is move on to case 2. Can you just go down to case 2 for me? There were some other things here, but we'll move to case 2 because I think I want to do with the next case. Yep, keep going for me. Next slide. Next slide.
Yep.
Yep, next slide. There we go. Okay. Case 2. So let's move on to case 2. Dr. Kazusaka.
Well, from here, I talk about the cases. So a 64-year-old lady visited our department complaining of the enlarging neck mass. From the fine needle aspiration, it revealed that it was an aplastic cell carcinoma. There was an 8 centimeter large and firm tumor on her left neck. It moved slightly when touched. She has no hoarseness, no dyspnea, and no dysphagia. White blood cell count was over 10,000, and neutrophil lymphocyte ratio was 3.7. This CT scan shows left neck lymph node swelling and then a tumor in left lobe of the thyroid. Both seem to have necrosis in the center of the tumor. The trachea was a bit distorted, and the muscle layer of the esophagus might be invaded by the tumor, but the carotid artery seemed to be intact. There's no evidence of distant metastasis on FDG PET. Right.
Dr. Khorsandi, you've reminded me occasionally that you don't make diagnosis off the CT scans, but we know you guys have a pretty good feel. When you look at anything about this that makes you think this is more than a run-of-the-mill, poorly differentiated papillary, what are you thinking here?
The jugular vein. I never see the jugular vein. I think, I don't have enough images, but I think the jugular vein is probably invaded by tumor, more than compressed. I think that's what concerns me the most about this case. Besides all the other stuff that I talked about in the last case,
Yeah. Mark, resectable, not resectable? I mean, I guess technically everything's resectable. It just means what you're going to have to take out with it. So how do you kind of make that decision?
Yeah, so it's, as Dr. Sugitani mentioned, the artery, carotid artery appears to be clear. I'm worried about that adenopathy. That looked very onerous, and worried about the interface between that tumor and the trachea. I think that's probably where this will be lost in terms of doing a complete resection. So I think at best, my expectation going in would be to do that I would come out with an R1 resection here. I don't think that one could get an R0. And certainly in this setting, doing more aggressive surgery to remove the trachea, which I think would be necessary, just wouldn't be warranted here. So, I think in the face of the absence of a BRAF, which obviously has changed our paradigm here, I think we have to contemplate surgery. And this would be, again, that multidisciplinary discussion as to whether or not upfront treatment could be helpful, knowing that this is almost assuredly a palliative setting.
Dr. Coura-Filho, I assume FDG PET's going to be the primary tool for nuclear medicine and anaplastic. Any other DOTA, any things I should think about and not understand?
No, at the present time, FDG is the best radiotracer for anaplastic thyroid carcinoma. And the fact that it's so undifferentiated as a tumor, it gives us a very high confidence when a negative FDG PET-CT is found for the rest of the body. So we can rely that no metastasis is likely to appear anytime in the next few weeks.
Maria, while we're talking about this, what else do you want to know about this tumor while we're deciding what we want to do?
Well, in terms of staging, I also just want to mention that we need to do an MRI of the brain. So these patients tend to have a very high rate of metastatic disease to the brain that's asymptomatic oftentimes. And so before you proceed with surgery or radiation, you want to do that. What else do we want to know? Well, the molecular testing is critical now. It should be done up front on every newly diagnosed ATC patient, whether you think you're going to use the information or not. So you want to specifically know whether the patient has a BRAF V600E mutation. That can be done in 3 very rapid ways. So the gold standard, which is next generation sequencing on tissue, takes several weeks. So what we do is that we do either BRAF by immunostain, which the turnaround time is about a day if you have the antibody on hand. You can do a BRAF by PCR very quickly, and you can also do liquid biopsy. So this we do for patients, for all of our patients, but it's very helpful for patients that have necrotic tumors where you don't have any cells really to work with.
Dr. Sugitani, you'd published many years ago, this. So talk about that prognostic index. How do you use that, Iwao?
Okay, we hope we use the prognostic index to determine the treatment strategy for ATC. It's a number out of 4 risk factors presented by patient. If the PI is low, we try a non-aggressive treatment, while the PI is high, we recommend only best supportive care for the patient. Her PI was 3, so the expected lifespan was around 6 months.
Yeah. So, Dr. Pitoia, while Dr. Cabanillas is ordering about $3 million worth of molecular testing, maybe not that much. Is that molecular testing available in South America? How does that sort of play into how we're making this decision here now, Fabian?
So we can only do BRAF in this patient provided by the laboratory who sell the drug. So it is covered, reimbursed the laboratory. It is fast and we can have it in 2 or 3 days. But the problem then is to find the reimbursement for the drugs, the raffinib if we have a BRAF positive patient. So we will have probably the result, and then we will have to wait until we have the approval of the drugs. So we usually do a bridging therapy with lenvatinib in this group of patients while we wait the approval of the raffinib that maybe take 2 or 3 weeks, and this is a lot of time for an anaplastic thyroid cancer.
Okay, Dr. Sugitani, let's show Dr. Cabanillas the sequencing data.
Okay, we conducted the next generation sequencing, and it revealed that the tumor has NRAS and TP53 and Tuttle promoter mutation. Unfortunately, there is no druggable mutation. Moreover, the microsatellite instability was stable and the tumor mutation burden was low.
Maria, most of the time, these cases, we always show you a BRAF1 that we can do, neoadjuvant, but the reality is that's what, 40% of all the anaplastics or something? So the reality is, where are we now? So we've got an NRAS tumor or a wild type. So how do you sort of frame where you are now?
Yeah, so we know that patients who have RAS mutations in anaplastic thyroid cancer actually do the worst of all of the patients. And so prognostically, this is not good. However, the patient doesn't have distant metastatic disease. And so the upfront treatment should involve, either surgery and radiation or directly to radiation. But because the patient has no distant mets. If the patient had distant metastatic disease, it would be a completely different conversation. The other thing that I would like to know, though, on the moleculars or on the pathology is what the PDL1 score is, because we do have data on PDL1 and anaplastic, that being the target for some of our checkpoint inhibitors. And so I would like to also have that information up front, because that may be a viable treatment for this patient in the future.
So say a word or two if there was distant mets, because right now, this case, no distant mets that we know about right now. We're headed down surgery and external beam radiation. If they had not huge volume distant mets everywhere, but definite distant mets in the lungs or somewhere, how does that change your thinking, Maria?
Yeah, so we categorize those patients into low volume and high volume distant metastatic disease. If this were a patient with low volume distant metastatic disease, we would probably we would consider doing full dose radiation, the 6 weeks, but we would scan them halfway through because these are such high risk patients, just to make sure that they haven't developed distant mets. If the patient had high volume disease, then we would be talking about clinical trials, about doing, very quick radiation to the neck, a palliative course, and then quickly putting them on a clinical trial or some systemic therapy to manage all of the disease. So it's a totally different conversation if they have distant metastases.
Really important point to just don't lose them for 6 weeks while they're getting the radiation and see what happens on the other side, right? And knowing what's going on there. All right, Mark, what are we going to do? So it's an NRAS mutation. There's no neoadjuvant stuff here. What are you going to tell the patient in terms of surgery, radiation? What's your plan?
Yeah, so I think a detailed look at that scan tells you where you're going to have trouble going in. I think in the absence of obvious breach of the tracheal wall and in the absence of carotid encasement, I think it's a reasonable undertaking. I think you're going to tell that patient that that we're not going to do a very extensive surgery that will involve tying them up for long periods of time prior to instituting additional adjuvant therapy. So I think the goal here is to remove what you see, and I don't think there's any role for doing a total thyroidectomy here. I think that left lobe and the isthmus and removing that disease in the neck would be the appropriate extent of treatment here.
Okay, Professor Sugitani, what'd you guys do?
Then we decided to perform radical surgery. The main purpose was not to let her die from miserable local causes, such as suffocation, bleeding, and so on. We carried out thyroidectomy and lymph node dissection. It ended up R1 resection, sacrificing the vagus nerve, sternocleidomastoid mastoid muscle, and the jugular vein. After 3 weeks, we started external beam radiation therapy on her neck. Here's a question, is total thyroidectomy mandatory in surgery for ATC?
I think Mark had already mentioned that in that setting, lobectomy, taking out the disease, not risking the nerve on the other side, not doing anything that's going to delay complications. So I think both of you were on the same page with that. Okay, let's look at the path report. The path slide.
Yeah, where did you have disease, persistent disease? Was it in the neck? Where do you have any idea where the R1 was located?
Oh, well, I can't follow your question. Sorry.
Yeah, do you know, was the microscopic residual disease on the tracheal wall?
Yes, right. Actually, not tracheal wall. It's the carotid sheath. Actually, maybe the very nearby rejection on the carotid sheath. Actually.
Carotid sheath. Okay, right where Mark was worried about it. Okay, let's, in the interest of time, let's look at the pathology report.
Yep.
There are slides.
This is the pathological findings here. That massive necrosis, the muscles and nerves are involved. Ki67 labeling index was over 30%. There's no differentiated thyroid cancer compartment.
And Zubair, any comments about that?
I don't think you need a pathology residency to call this cancer.
Got it.
Because this looks pretty bad. And then you have definitely necrosis. I don't see any differentiated component. I do want to point out that this is a resection, but the problem for the pathologist is on a very small biopsy to call it outright anaplastic cancer that is coming from thyroid, because even bad squamous cancers can look like this. But now we have good markers to at least point out on the small biopsies. But this is, you know, looks like an undifferentiated carcinoma, which is the other name for anaplastic carcinoma.
Okay, so let's go ahead with the case, Dr. Sugitani, and talk about the systemic therapy that ended up.
Yes, only 18 days after the initiation of radiation, she developed local recurrence at the right lateral neck and mediastinum. The recurrence was not seen in the right lobe of thyroid. Thereafter, she enrolled in the investigator-initiated trial with lenvatinib with nivolumab. Are there any options?
So, Dr. Pitoia, in your setting down there, the setting of distant metastasis in the anaplastic, what lines, what therapies would you guys be thinking about?
We would go with our oncologists to do traditional chemotherapy. We cannot do anything else at this moment.
Maria, look, I mean, obviously Lenvima is going to be here. Looking forward, you know, studies that's in trials. You guys are right on the cutting edge of this. What are we going to be looking at in the near future or distant future, you think?
Yeah, so obviously this is a regimen that a similar regimen has been studied in a clinical trial in Germany, and we're studying lenvatinib pembro also, and they have a median overall survival of 11 months. So this is a good choice. RAS-mutated disease is just very, very difficult to manage. There are other trials, but I think I would recommend this first before anything else. But we have, for example, CAR-T trials. We have, you know, tumor infiltrating lymphocyte trials. There's not much else for RAS-mutated disease. We've tried a MEK inhibitor with immunotherapy, and, you know, with some success, but probably not as good as lenvatinib pembro, or in this case, similar drug nivolumab.
Okay, all right, let's look at her course before we go on to the third case. Dr. Sugitani,
Sure.
next slide here.
Yep. Treatment course of the clinical trial is shown. She suffered from cholestasis, probably due to lenvatinib, and we needed to suspend and reduce dose of the drug twice. Eventually, she underwent cholecystectomy, and we have resumed treatment again very recently. Aside from this, NLR seems to reflect disease status in ATC. Thanks to the therapy, the tumor decreased in size a bit. Fortunately, she has not developed distant metastasis yet. It's the for case 2.
Now, Maria, let me let you finish up. You'd mentioned that these NRAS anaplastics have sort of the worst overall survival. Your guys' data showed that really nicely. What's the expectation here? I mean, you've got reasonable control on the neck. We don't have widespread distant metastasis. But I mean, for the family, is this 1 year, 2 years, 5 years? Any feel for that?
So we always say that if you can get them past the first year, that there's possibly a chance that they'll live another year or so. Localized disease, of course, is very different from, if they become metastatic, these patients get very sick very quickly and they die. What we've been doing is that we've been putting patients on an adjuvant trial with pembrolizumab, because we know that the risk of them developing either progression in the neck, even after radiation, or distant metastatic disease is incredibly high within the first year. 71% have a relapse. And so, so we're trying to prevent that. We don't have results, obviously. We just started the trial, but I think we do need to, we need to treat this as a very high-risk disease and kind of throw the kitchen sink at them.
Yeah.
Yep. Yeah, Maria, is that CPS score dependent or across the board?
No, it's across the board. We're not looking, we are looking at the PDL1 score, but we're not using it to put patients on trial. It's not an entry criterion.
Very good. Well, after 2 challenging cases, we all knew we were not going to let Dr. Sugitani do this tumor board without presenting at least somebody to do active surveillance on, since started active surveillance.
A bit of a tricky case with a very low risk thyroid cancer, actually.
Perfect.
Okay. A 39-year-old gentleman was referred to a department due to the right side nodules, which were detected by ultrasound examination on the health checkup. At the previous hospital, FNA was done and the diagnosis was papillary thyroid carcinoma. The tumor was located in the middle of the right lobe and it was 9 millimeter in the maximal diameter. He also had another small tumor in the same lobe, measuring 10 millimeter. There's no extrathyroid extension or lymph node metastasis. So, which option do we recommend?
Get this echo, so I have to keep turning on and off. Dr. Pitoia, what do we do in Argentina? So this is multifocal papillary microcarcinoma in clearly a young man. We would both agree with that.
Yeah, we probably will talk with the patient and to understand exactly what is the mentality of this patient. We won't oppose directly to active surveillance, although this patient has a multifocal disease. We could do that. But we will explain that the published experience is not much with active surveillance in multifocal disease, and probably we will feel more comfortable with surgery. But if the patient would choose to do the active surveillance, we would go with him doing it and going with him with this decision.
Dr. Cabanillas, this is the opposite end of the spectrum that you play on. So I assume there's no neoadjuvant. You're not going to ask for next generation sequencing. So
absolutely not.
In Texas, what are you guys going to do with these?
Yeah, we would do the same. We would encourage surgery. But if the patient wanted active surveillance, we could watch them for a time because it's young. Especially if the patient had something they needed to get done, like finish, whatever, their dissertation, then we can always delay surgery.
Dr. Urken, there's a rumor around New York that you've occasionally been known not to operate on a patient. It's just a rumor. It's not been verified. You watch some of these with active surveillance with me. How do you make that decision? And, he's young, it's a guy, it's multifocal. So how do you think through that, both in terms of imaging and sort of what the patient wants and their expectations, Mark?
Yeah, well, the first thing I carve out about 4 hours of time in my office to have this discussion. It's disproportionate to the size of the primary tumor. But having gotten through that part of it, we look at a number of things that have been widely published. One is the location of this tumor in the thyroid lobe and whether it's in a favorable or an unfavorable location. I also go back and look and see if there's any prior ultrasounds that might give me a hint as to what the rate of change has been in the past, and that's often helpful. Obviously, the absence of nodal disease is extremely important. I'm less decided about the multifocal nature of this as to whether that really plays a role, as long as that. So I sort of put that on the back burner, but it's one more factor. I think the biggest issue is what comes down to the psychological effect of impact of living with disease in the neck or having it removed. And we talked about this extensively, but I think that's where probably 2/3 of the discussion will come down to.
Perfect. Dr. Sugitani?
Okay. According to our conservative way of thinking, Japanese consensus statements say younger patient and patient with multiple lesions still can be candidates for active surveillance. After shared discussion, he made the decision to undergo active surveillance, actually. However, 1 year later, he changed his mind and decided to have surgery, although the tumor status had not changed. You can imagine now what made him change his mind.
Dr. Pitoia, Fabian, you've got a series of some active surveillance in Argentina. Talk about a little bit why they changed their mind or don't change their mind, or the decision making there.
I think that the mainly other physicians has a lot to do with the change of mind of patients undergoing active surveillance. We have seen it like in 10% of our series, this situation where what the worst thing a doctor can say, if I would have these, I would have removed my thyroid gland in 1 second. And so the patient came back very nervous, and sometimes even we see the patient when they came back operated on with no asking us what they would do. So this is something that continue happening. So I advise my patients under active surveillance not to talk to anybody about the decision and continue with this only with us, only with the doctors we are following them.
You're absolutely right. It's we have about the same number as Dr. Sugitani in terms of changing their mind. It's not very many. Most people stay in there. Sometimes it's because there's benign changes on the other lobe or non-specific lymph nodes, or I've had 2 patients that needed organ transplants, but they couldn't be transplanted until their cancer was treated. A couple patients that needed parathyroid surgery on the same side, so we just dealt with the thyroid at the same time. And then the other ones have been pressure from family members or pressures from other stuff. In the United States, I've had a couple people have to change their mind because they couldn't get long-term health insurance because you had to be cancer-free for 5 years. So there's a lot of reasons beyond just the tumor that made us do that. So in his case, Iwao, what was the story here?
Okay. Here, we'd like to briefly review the Japanese medical care system. Under the universal public health insurance program, everybody in Japan can receive the same medical care with the same inexpensive price. However, more than 40% of people in Japan take out private cancer insurance. Indeed, it covers a good amount of expense for cancer care. But the coverage does not reach the person without histological diagnosis. And more importantly, people are not allowed to join private cancer insurance when they have even a minute cancer. As a matter of fact, his wife persistently persuaded him to have surgery.
Yep.
So we have appealed to insurance companies on the basis of our consensus statements and position paper. Eventually, one company has admitted patients with low-risk thyroid cancer and active surveillance to join the cancer insurance plan, excluding compensation for thyroid cancer.
Yeah, it's a challenge, right? Even in the United States, I've had 1 or 2 patients choose to have their surgery at Memorial, even though they were stable for 8 years, because they were retiring to a different part of the country and they didn't know the medical team. I've had other people on purpose choose to watch for a set period of time. We call this our bridge program. They want to watch until they get married in 9 months, or they want to watch until a couple of policemen are going to retire, or professional voice users. They have no intention of watching forever, but it just takes the pressure off them and gives them that release. So I don't see somebody changing their mind as a failure of active surveillance. I see that as success. That means we're still having the conversation. I routinely tell the patients, I can change my mind once a year. You can change your mind whenever you want to. And I think that's the success of active surveillance is operating at a time when it's still effective, regardless of the reason, whether it's slight progression or whether it's patients changing their mind. So I think that, we're just being honest about what really happens when you follow these people. And I think being sensitive to that when you first meet them, right? If they're one person in the room and their 6 family members are all rushing to get to Dr. Urken before he finishes on Friday night, it's a different sort of conversation. Mark, how much do you really sort of, like in multifocal, I'm the same way. I don't worry about that too much. How do you sort of gauge what the patient wants or doesn't want? I mean, sometimes you're just really quiet and listen to you talk. How do you sort of have that conversation to sort of figure out whether they're kind of a minimalist or a maximalist? And there's sort of an art to that. How do you sort of advice on having that conversation?
Yeah, it's really challenging, and you sort of have to be able to read the room carefully. I kind of like the idea of the cone of silence. That seems like interesting. Get smart. Those of you who remember Get Smart, that you sort of put your blinders on, and once you make that decision and move forward. But now in the pandemic era, you have to read their eyes, and they're very revealing. Having a discussion with somebody who's got thyroid cancer or any cancer and say we're going to watch it, often that look of in the eyes tells you can pretty much give short shrift to active surveillance. And so it's both the patient and the significant other that really give you the clue. So usually try to be as giving equal shrift to each of these 2 options, but oftentimes that patient will declare themselves very early on here.
Yeah, I've noticed it much more a challenge when I'm on Zoom. When I'm in the room with everybody, I can actually see all the family members. Sometimes on Zoom, it's somebody off camera that's given a thumbs down and you can't see that and address to that. So that's been a challenge. All right, we've got about 2 minutes left. These are wonderful cases. Let me put Dr. Cabanillas on the spot and then Dr. Pitoia. Dr. Cabanillas, from the aggressive thyroid cancer standpoint, what are our take-home points for the ones of us that don't work in fancy ivory towers like you guys and are out there seeing patients? What's the take-home message, Maria?
Yeah, I think for highly aggressive thyroid cancers, particularly for anaplastic, we do need molecular testing. For ATC all patients, for differentiated and medullary thyroid cancer, there are now guidelines that we've put out for who should have molecular testing. I think pathologists need to also help us with ATC by doing upfront BRAF by immunohistochemistry, not waiting for me to ask for it. This should be a reflex test, just like you do ER/PR for breast cancer. You would never not do that. I think that needs to be done for ATC now.
Beautiful. Dr. Pitoia, from the low-risk side for our clinicians.
So considering active surveillance, I think that we need to start thinking as this as an option and to offer this as an option to our patients. And of course, considering localization. And I want to promote your recent paper. I have read this wonderful paper showing the kinetics, confirming what was already published about the kinetics, but it's so interesting to see that there is different kinetics of these tumors, and we have to understand which kind of these kinetics represent these patients.
Dr. Sugitani, any last words before we finish?
Thank you for giving me opportunity to the way of thinking from Japan. Thank you very much.
Fantastic. And rumor has it Japan is going to open for tourists in about a month. I highly recommend to go visit. Go visit Cancer Institute Hospital. I've been there. He'll take you to lunch. Stop by, tell him I said hi. Thank you, panel, for a wonderful, wonderful discussion. And thank you, Dr. Kazusaka and Sugitani, for wonderful cases and presentation. And we'll finish for the morning. Thanks, team. Bye-bye.